medicine. By profession, I'm a pediatric critical care physician at Stony Brook Children's here in Stony Brook, New York in USA. I'm here to give a talk about a paper published in Med Portal last year. Med Portal is the educational material journal for the Association of American Medical Colleges. I'd like to give you more information about our findings. No conflicts of interest is disclosed. The main disclaimer I would give is, although I'm currently at Stony Brook, the information, the data that I'm going to present was during my time at University of Chicago when I was in my Pediatric Critical Care Fellowship some years ago. So just to let you know about that, but otherwise no conflicts to disclose. So the main challenge that I met during my fellowship training at University of Chicago was that there was a dire need for an educational curriculum, especially for the residents and students who are rotating through our pediatric ICU. The problem, as with other ICUs, our ICU was a 24/7 active, very busy unit. And we had patients of varying levels of acuity, severity, complexity. And the medical teams comprised of students, residents, fellows, and attending physicians varied, where the students and residents could change every 2 to 4 weeks. And the educators, being the pediatric ICU fellows and attendings, could vary weekly. And as you can see, or as you can imagine, the education to our students and our residents also varied based on who was on service regarding the educators. A lot of factors played into the variability regards to the various levels of experience with education, and also core topics that each educator felt comfortable teaching. And so as a result, a lot of students and residents left the unit, although appreciative of the experience in critical care, often very distraught in that some people got an amazing educational experience and some left with very little formal didactic teaching. But with all of this, the American Medical Association, in conjunction with the Accreditation Council for Graduate Medical Education, recommends that these students and residents receive exemplary training and educational experience during their time in the ICU when, learning to manage and stabilize critically ill children. So there was definitely a need for a curriculum, at least, that we could enforce or enable a more, I would say, where everybody got essentially the basic knowledge that they were expected to have before leaving the ICU. So when we looked at how learning was occurring in the ICU before the implementation of this curriculum, it's as similar with other clinical training and other clinical settings where experiential learning takes or is a big part of it. Experiential learning comes from Kolb's experiential learning theory, where you initially start with the concrete experience where the learner's engaging directly in an authentic situation. Once that experience has occurred, then there's reflection going on where they notice what happened, relating it to past experiences, and trying to merge it with conceptual understandings. After that, then they go on to abstract conceptualization, where they're then distilling perceptions into abstract concepts. Then after they form these concepts, they then test them, testing these new ideas, honing skills in this new experience, and then they then move on to experience new things to start the cycle over again. And even though a lot of times we do this subconsciously, this is how we learn in the clinical setting from experiential learning. So we were looking for a way that our curriculum would enhance or supplement this existing experiential learning to facilitate learner not just knowledge acquisition during their time in the ICU, but also how well they retain this information months after they've completed their rotation in the ICU. So looking at what had already been done prior to our formation of this educational curriculum, there was a publication in Critical Care Medicine in the 90s, Cullen et al., where his group didn't really tell us more specifics about the actual curriculum, but did give us the effect or impact the curriculum had, where they were able to demonstrate knowledge acquisition amongst their PICU residents. Their test scores, however, didn't correlate with the attending's perception of each individual resident's performance, which I thought was an interesting finding, but they did not test for any retention of the knowledge that they acquired during the IC rotation. There was another publication from Hegg et al. About 11 years ago, where they did also implement a didactic curriculum in the PICU. Once again, demonstrated knowledge acquisition, but once again, knowledge retention was not tested. So there was a huge gap with in the literature with people actually able, testing how well knowledge is being retained after completing the rotation when it comes to didactic teaching. There was another publication in Metaportal within the past 10 years from ours by Cora and Kritek. However, theirs was a case-based didactic focused on adult ICU curriculum, where although some of the concepts are very similar, there's definitely some differences in the pediatric ICU curriculum worth noting. So we thought that it was definitely a need to not only see what our curriculum, what impact it would have on our learners, but also to be able to get the information out there so that others could utilize it and potentially build upon it. So when our hypothesis with moving forward with this curriculum development was that when we implement this standardized curriculum, we will be able to facilitate not just knowledge acquisition, but also retention. The curriculum will improve the learner's overall satisfaction in their educational experience in the PICU, which prior to the implementation of this curriculum wasn't the best satisfaction rate. And then we will improve the learner's perceived confidence in their own knowledge, and that this perception and their confidence will correlate with their knowledge acquisition. So we embarked in a prospective cohort study started in late 2015 and ended in mid 2017. Our learners being pediatric residents and internal medicine pediatric residents during their 4-week PICU rotation. We had other learners, including emergency medicine residents and students, but we decided not to include them because their rotation schedules were completely off, and it made it very difficult for testing and reliability of our results and potential confounders. So we decided to not include them in our results, but to proceed. The educators were the PICU fellows and faculty. The fellows could be as novice educators, being first-year fellows when it comes to teaching pediatric critical care medicine, and the fellows could go up to 3rd or 4th year fellowship, 3rd or 4 years in their fellowship, where they're more experienced in educating in their pediatric critical care medicine. The curriculum comprised of 13 standardized educational modules, and each one was standardized based off of learning objectives that were put together based on what was recommended by the American Board of Pediatrics as to what every pediatric resident needed to know leaving the ICU in preparation of their pediatric board exam after their residency. And then what was probably unique with our curriculum was that we actually included these teaching guides, and the teaching guides not only were content guides for the educators, but also showed them how to teach it in certain sections and to pace them appropriately. So it was definitely of much help for our more novice educators. And then we also made sure that quality assurance was done throughout this project. The outcomes we focused on were knowledge acquisition, and that's by comparing testing, knowledge testing at the end of the curriculum compared to the pre-test at the beginning of the curriculum. And then we tested them 3 months afterwards, about on the same topics to identify any retention of the knowledge they've acquired in the PICU. We didn't want to do too much further out than 3 months, given that some residents then would come back to the PICU for their second or third rotations, because a lot of residents had 2 to 3 months of time in the ICU throughout their 3 to 4 year residency. So we thought 3 months was a good enough time, far out from the rotation, but not too far out, where then there's other potential confounders. And then we measured their level of confidence at each time we tested them. The core PICU topics that we decided upon were identified and agreed upon by our senior PICU faculty. And so by no means were they exhaustive of what was important to know in the pediatric ICU, but within the list, these were identified as the top 13. So I wanted to show you guys an example of the teaching guide I'd mentioned earlier. So for every topic and module, there was a teaching guide made available, and also a PowerPoint. And so I'm going to go through some of the good features or positive features of this teaching guide. So first of all, especially for our novice educators, it provided clear guidance for pre-lecture preparation, what was needed, how long the lecture, the duration of the lecture, which should be, and all of these were provided as part of the curriculum in our publication and meta portal for anyone to be able to pick up and utilize. Also, they allowed for flexible teaching style. We know that some people feel very comfortable with just PowerPoint teaching. We wanted to encourage people to do more, using dry erase boards and markers to facilitate more learner engagement and more conversation during their lectures, as opposed to just giving the information to the learners, because this more interactive learning might actually facilitate more of the retention, knowledge retention that we were hoping to get. But needless to say, we allowed for flexible teaching style and provided the PowerPoints with each one. Also, that these were 30-minute didactics, so it gave really the nuts and bolts, the really important things that were important for the residents to take away from the lecture, not limiting educators if they wanted to do a longer lecture if time allowed, or if they wanted to do teaching on the same topic on a different time, that was allowed. But we made sure that every student and resident that came through the ICU received the same basic and or baseline information. And then we also then had the teaching guides divided in sections and pasted appropriately and matched up to the slides with the accompanying PowerPoints to make sure that these novice educators definitely had a little bit more guidance with how to teach it, so that make sure people were teaching the information in a more uniform fashion across different sets of residents and students. So as a total, we had 78 resident physicians who participated. Mostly, I mean, as I mentioned, these are just looking at the pediatric and medicine pediatric residents, 60 of which actually completed all of the pre-test, the post-test, and indicated levels of confidence. We had to exclude those where we were missing data, just to make sure that we had matched numbers for our data analysis. However, we had a really low response rate once they left the ICU in regards to obtaining their follow-up testing. And so we only had 15% of this 60 learners who completed the follow-up test. Regarding their test scores, these are the matched mean test scores. So the mean test score for the pre-test was 55% for these 60 learners, and in comparison to their post-test mean, which was 64%, there was statistically significant difference between the two. However, when we compared the post-test scores to the follow-up test scores, which the mean follow-up test score was only 62.2%, there was no statistical significant difference. So that to us kind of indicated that likely there was some retention, but also kind of difficult to generalize that, given that we had really poor follow-up tests filled out by the residents and students. When we looked at the level of confidence in their knowledge after the curriculum, we definitely saw an increase in the level in the large majority of the students, and 82% of them. And this was, we tested the level of confidence by asking them how they felt their level of confidence was using a Likert scale, starting with very poor to very high level of confidence. Regards to their satisfaction in the curriculum, a lot of them were very satisfied in the curriculum. As I mentioned earlier, this is hugely different compared to how it was prior to the implementation of this curriculum. We didn't have the numeric data to actually demonstrate this, but just from our conversations, very informal, interviews or just by way of word of mouth, this is much improved. A lot of the residents really appreciated having this curriculum in place. As I mentioned, there were definitely some limitations, but there's more to talk about. We know this is a single center, not a huge N, but for the short amount of time that we had in collecting the data, I think we got a good enough amount of information, at least to encourage more testing in regards to this curriculum, and potentially trying to put together a curriculum with other teaching methods. Another thing is junior fellows, PICU fellows, sometimes may require more than 30 minutes, but I think for the large majority, they were able to stick to the 30 minutes, especially because it was the only protected time the learners had to get the lecture. So that really pushed them to stick to the 30-minute time slot. As I mentioned before, the learners that we assessed were restricted just to the pediatric and the medicine pediatric residents, given that the emergency medicine residents and the students had different rotation schedules. And so we didn't really get to see how the knowledge retention may have been had we assessed these other groups. Also, if you notice, the test scores across all the different tests were really poor. And I think this was more just speaking of how difficult probably the test was, which was something that we learned as we were really going into it, but that's to not change the test. In the middle of data collection, we just continue to use it. However, for future curricula or testing, definitely might be better to adjust the test where it would be more aligned with what's, expected for the students. But we made the test based off of the learning objectives for each of the lectures. Also, the low follow-up test response rate was also a huge limitation, which is also one of the reasons why a lot of studies don't have a lot of retention data in regards to this curricula, because it's hard to capture these learners once they've left the rotation to get them to fill out the response or the follow-up test. Also, it's difficult to differentiate the improvement in their tests between their pre and post tests from the impact of the curriculum versus the experiential learning that's already going on in the PICU before the curriculum is implemented, and other teaching that may happen in the ICU. But we're hoping that if anything, the curriculum just facilitated or enhanced this learning that's already happening, just to increase their knowledge acquisition and potentially enable more knowledge retention after the rotation is completed. So future directions, as I mentioned earlier, the development of a curriculum, a PICU curriculum, utilizing other teaching methods would be definitely advantageous. I think looking more in case-based learning, which I would think is much more impactful, looking at simulation incorporation in the curriculum. Also looking at curricula across for other disciplines. I know in the past couple of years, there was a publication in Pediatric Critical Care Medicine Journal where they actually looked at a nurse practitioner curriculum for the pediatric ICU. I think having one for a nursing curriculum would be of great advantage, or even a curriculum where there are multiple disciplines that is reaching. I think that would be really good to look at. Also, multi-center use of a standardized curriculum would serve with many advantages, especially with focusing on knowledge retention, the impact on patient care, and potential incorporations of these other disciplines as learners and or educators, I think will be really important, as we know that in the ICU is not just the physicians involved, it's also our nurses, our ancillary staff, the respiratory therapists, our pharmacists. So getting them all involved in the curriculum, I think might be important to see how that would work. So this here concludes my presentation, and I welcome any questions.
Okay. Thank you very much, Dr. Uchechi Oddiri, for the wonderful presentation. I'd like to open the session for questions. Any questions for Dr. Oddiri? You can raise your hand, or else you can directly ask. You can give your question in the chat box.